friends, let us come to the next topic of glomus tumor. So now, glomus is the most common benign tumor of middle ear. Let's look in this photograph. Okay, you can see that this is a vascular tumor, as you can see in this diagram. Okay, so this is a vascular tumor in the middle ear. This is the most common benign tumor of the middle ear. Now this glomus tumor, it arises from paraganglionic cells, okay, the juglotympanic paraganglions, or you can even call them as paraganglionic cells. Now these cells are found in association with Jacobson's and Arnold's nerve. So we know that Jacobson's nerve is a branch of the glossopharyngeal nerve, 9th cranial nerve found in the middle ear, and we also have the Arnold's nerve, branch of 10th cranial nerve, vagus nerve, again found in the ear. Let's look at this diagram. So what do we see in this diagram? You can see the external ear, you can see the middle ear, you can see the inner ear. Okay, you can also see the facial nerve. So that blue dot is the facial nerve. Okay, on the promontory you can see another blue dot, that is the dot for Jacobson's nerve. Okay, so that's a cross section of Jacobson's nerve, branch of glossopharyngeal nerve. Now then, around the internal jugular vein, so you can see that this is the internal jugular vein, we have a few cranial nerves. Which cranial nerves? They pass through the jugular foramen along with the IJV. We have the 9th, 10th and 11th cranial nerve. Okay, along with that you can see the branch of the 10th cranial nerve, that is your Arnold's nerve. And finally, going a little separate, through the hypoglossal canal, we have over here the 10th cranial nerve, the hypoglossal nerve. Alright, so now around the Jacobson's nerve and around the Arnold's nerve, we have these paraganglionic cells. Okay, and these paraganglionic cells, they give rise to glomus tumor. Okay, now based upon these paraganglionic cells, we can divide the glomus into two types, glomus tympanicum and glomus jugulare. Okay, now the glomus tympanicum, let's first talk about the glomus tympanicum. Now this glomus tympanicum, it arises from paraganglionic cells around the Jacobson's nerve. So Jacobson's nerve is on the promontory, on the medial wall of middle ear, as you can see. So this glomus tympanicum, it arises along the course of Jacobson's nerve on the promontory. Right? Okay. So because it is rising from the promontory, now which cranial nerve it will first involve? It will first involve the 7th cranial nerve, the facial nerve. Okay. So it will first cause the palsy of the facial nerve, then it will proceed and cause the palsy of the other cranial nerves. Okay. So that's a glomus tympanicum. Let's look at the glomus jugulare. Now the glomus jugulare, as you can see over here, now this glomus jugulare, it arises from the paraganglionic cells which are on the dome of the jugular bulb. You remember the Arnold's nerve, around that we have the paraganglionic cells. So it arises from those paraganglionic cells which are on the dome of the jugular bulb. Right? Okay. So therefore, you see, this will first cause palsy of 9th, 10th, 11th and 12th cranial nerve. As you can see, I have marked this red area. So these are the parts which will be affected first. 9th, 10th, 11th and 12th cranial nerves will be the nerves which are affected first in glomus jugulare. Okay. Now, sometimes we can even have a bleeding oral polyp. So patient presents to us. Now there is a polyp which is coming out in the EAC and there is a history of bleeding. Okay, so remember, if a patient comes to you with a polyp in the EAC and there is history of bleeding ear polyp, never attempt a biopsy before doing a radiological investigation. Okay, so patient comes with bleeding oral polyp, never do a biopsy. First, you must always do a CT scan, a radiology investigation to find out whether it is glomus. Okay, because it can be glomus, it's a vascular tumor. If you take a biopsy, then you will be in a trouble. The patient will be in a trouble, so you will also be in a trouble. Okay, so remember, sometime patient presents with bleeding oral polyp, then you cannot say whether it is a glomus jugulare or a glomus tympanicum. That means it is already proceeded in an advanced stage, it is coming in the EAC, so you don't know from where it is taken in origin. Right? Okay. Now, another question which is asked in the exam is the most common blood supply of the glomus. So, answer is inferior tympanic branch of ascending pharyngeal artery. Okay, so remember, ascending pharyngeal artery, that is the medial most branch of the ECA, external carotid artery, and from there comes an inferior tympanic branch that supplies the glomus tumor. This is the most common blood supply, and this question is asked in the exam, right? Okay, now how will the patient present? What is the clinical presentation? You see, this is a vascular tumor. It's a mass in the middle ear. Okay, so it's a mass in the middle ear. The patient presents with hearing loss. Okay, patient age is generally 40 to 50 years. Female to male ratio is 5:1, much more common in females compared to male. You can see the ratio is 5:1, right? Okay, and the patient comes to you with conductive hearing loss. But we have seen conductive hearing loss is present in so many different conditions. Do we have something specific for glomus? Yes, the patient has pulsatile tinnitus. Remember, it's a vascular disease. So what will happen? You know, the internal jugular vein, it will bring the pulsations from the heart. So with every pulse, there is a sound. Okay, there is a ringing sound in the ear. Now this sound is synchronous with the pulse because it is coming with every pulse. So patient has pulsatile tinnitus. Now this pulsatile tinnitus is a very significant complaint, and it should point the diagnosis towards glomus tumor. Okay, so whenever the patient comes and tells you about the tinnitus which synchronizes with the pulse, then you know you should think about glomus tumor. Okay, right. Now, other than that, as I told you, patient can also have a profusely bleeding polyp. Okay, if that is there, never attempt a biopsy. All right. Now, what do you find on examination? You'll find that there is a reddish tumor. You see over here in this video, you can see that there is a tumor which may be arising from the floor, from the hypotympanum. Okay, so this is a red tumor arising. This is known as rising sun sign. You can see that there is some pulsation in the tumor. It's a vascular tumor. Okay, so you can notice there is some pulsation like this in the tumor. So that is also seen sometimes. You can see this pulsation, so that means it's a vascular tumor. Okay, so this sign is known as rising sun sign. Okay, so rising sun sign, there's a reddish blue tumor growing from the hypotympanum. Okay, other than that, we can also see equinosign. What is equinosign? You take your fingers and you press on the internal jugular vein. So when you press on the internal jugular vein, you stop the blood flow. So when you stop the blood flow, what will happen? The tinnitus improves. So equinosign, you put the pressure on the neck, on the jugular vein, and the tinnitus improves. That is known as equinosign. Okay, now what else can you do? You can do seagulization. So you use a seagull speculum and you do seagulization. So that means you increase the pressure in the EAC. So when you increase the pressure in the EAC, you see it's a venous tumor. Okay, it's a vascular tumor, but it's a venous tumor. So what will happen? When you increase the pressure, the blood will drain away. So this tumor becomes white. It blanches. On seagulization, this tumor blanches. Blanches means becomes white. Okay, so we have a reddish blue tumor. It becomes white, it blanches. Okay, it is known as brown sign. This sign is known as brown sign. Okay, reddish blue tumor becomes white, sign is known as brown. Okay, remember, brown sign is also known as pulsation sign. Why? Because the tumor not only becomes white, but it also starts pulsating. Okay, it starts vibrating. So it is also known as pulsation sign. Okay, brown sign or pulsation sign. So now, as I told you, it's a vascular tumor. Therefore, you cannot do biopsy. How will you confirm your diagnosis? To confirm the diagnosis, we do contrast enhanced CT scan. This is the investigation of choice. Okay, why don't we do MRI? It's a soft tissue tumor. Because we have to see the bone, not just the soft tissue. We have to see the bone. Which bone? Craticojugular crest. So I've already taught you that in the middle ear topic. Floor of the middle ear, craticojugular crest. And if this crest is eroded, you cannot differentiate between ICA and jugular bulb. That is known as Phelps sign. Okay, so we have already discussed Phelps sign, inability to distinguish between ICA and jugular bulb due to erosion of keraticojugular crest. This is known as Phelps sign. It is seen in glomus tumor, contrast enhanced CT scan of glomus tumor. Okay, let's look at this. So what do we see over here? Look at the first photograph. You can see over here the star marked over here. Now let's come to the CT scan of this patient. So what do we see over here? You can see over here there is a star mark, that's the jugular bulb. Okay, over here you can see that this is the ICA. All right, so that I'm trying to tell you, you don't know how to read these CT scans. It's all right. Okay, just remember, I have marked the ICA, I have marked the jugular bulb in the axial cross section of this patient. Okay, in between them you can see that there is a thick bony crest that I have encircled. This bony crest is known as craticojugular crest. Okay, so this is a normal CT scan. Let's look at the other CT scan. In the other CT scan also, I am marking the ICA. This is the ICA. Okay, and this is the location for the jugular bulb. Now what you see over here, you see that this bulb is expanded. Okay, and if you notice, there is hardly any crest left. You see the craticojugular crest is almost eroded. Okay, very thin line is just present and the rest is all eroded. Now the ICA and the jugular bulb, they have almost become one. Okay, so that is known as Phelps sign. This sign over here, this is known as Phelps sign. Okay, seen in glomus tumor, right? Okay, now before we finish the topic, let us look at the staging for the glomus tumor. So I'm going to teach you the fish classification for the glomus tympanicum. So now let us come to the fish classification for glomus tympanicum. So now I'm going to teach you the staging for the glomus. This is the staging for glomus tympanicum. Fish classification. Now we know the glomus tympanicum, it arises from the Jacobson's nerve. So paraganglionic cells which are around the Jacobson's nerve on the promontory. Okay, so we have the type A, the stage A. So what is type A? Type A is limited to middle ear. Okay, so type A, it is limited to middle ear. Right, now when this involves the middle ear and the mastoid, okay, so that is known as type B. Okay, so type B limited to tympanomastoid compartment, not tympanic cavity as well as the mastoid compartment. All right, so that's known as type B when the tympanomastoid compartment, tympanic cavity spreads to the mastoid. Okay, now type C. What is type C? Type C is when it goes to the below the inner ear. Okay, so we call it as infralabyrinthine. Okay, it takes the root below the inner ear, infralabyrinthine, or it reaches the petrous part of temporal bone, petrous apex. Okay, so you see what is going over here. You can identify the internal carotid artery. You see, this is the ICA. So the ICA is going from below, taking a turn medial to the eustachian tube and then going up into the cranial cavity. Right? You can see the course of ICA over here. Now, if it is going into the infralabyrinthine, what will it involve? You see over here, it involves the vertical segment of the internal carotid artery. So C, the type C I can divide over here into the type C1. C1 means limited involvement of the vertical segment of carotid artery. Okay, type C1 is limited involvement of vertical segment. Type C2. C2 means, you know, a lot of, now the vertical segment is largely involved. C3 means even the horizontal segment is involved. Okay, so we have the C3, the horizontal segment is involved. Okay, that is C3. And now if the tumor goes to the cranial cavity, if there is an intracranial extension, so now intracranial extension is known as type D. Type D. Okay, so type D is intracranial extension of the glomus tumor, right? Okay, so once again I will write over here for you. Type A was limited to middle ear. Type B was tympanomastoid compartment. Okay, type C was involvement of ICA. C1. Now, what is C1? Limited involvement of vertical segment of the ICA. Okay, C2 is the, again, it's a large vertical segment is involved. That will be C2. And what is C3? C3 is the horizontal segment of ICA is involved. Okay, and then I told you D, type D is intracranial spread, intracranial involvement. So it has gone to the cranial cavity. Now this also you can divide into D1 and D2. So type D1 less than 2 centimeter spread into the cranial cavity, and D2 is more than 2 centimeter spread into the cranial cavity. Okay, so this is the fish classification for glomus tympanicum. Okay, now this is a vascular tumor. So what is the treatment? The treatment is surgery, surgical excision. This is the treatment of choice. Okay, remember it's a benign vascular tumor. Okay, so treatment is only surgical excision. Let's look at this. This is a case which presented with a small glomus tympanicum limited to the middle ear. So that means it was type A. Okay, glomus tympanicum. Look in the CT scan, you can see a small tissue over here. Here also you can see the tissue, right? So this is a small case. You can see on endoscopy there is a glomus tympanicum. So now we are doing an endoscopic excision of this tumor, right? It is limited only to the middle ear. You can see the incus, the stapes, the promontory. You can see the tympanic membrane in the tumor. Okay, so with the help of this cautery, we are able to remove this tumor. So you can see that we have first taken out the blood supply of the tumor. Now we have done the staging of the glomus. Let's talk about the treatment. Now see, it's a benign tumor. So treatment is surgical excision. That's the treatment of choice. Okay, let's look at this patient. So we have this patient who presented with glomus tympanicum. So you can see the tympanic membrane finding. This is the rising sun sign. Okay, you can see the typical rising sun sign. Now, what we are going to do, we are going to investigate this patient. So how do we investigate? We do a CT scan. So what do you see over here? In the CT scan, you can see a soft tissue in the middle ear. Look over here. In the middle ear, you can see a soft tissue. Now, this was limited only to middle ear. So now you can see that surgery is planned. We are doing an endoscopic excision. So this is the tumor, glomus tumor. You can see the incus, the stapes, that's the promontory, the tympanic membrane anteriorly. So with the help of this handheld cautery, we try to cauterize the blood supply. So now you can see that this tissue is being dissected out. The glomus tumor, we are dissecting out from the promontory. Okay, so slowly with the help of cautery, you dissect out the tissue, and then we are cutting out whatever is left over. Okay, so whatever is left over or the fibers of this tumor which are adherent to the wall, we have removed it in complete toto, and then we are putting the tympanic membrane flap back. So this was an endoscopic excision done for the glomus tumor. All right, that was A very small tumor, so we could do an endoscopic excision. Otherwise, generally bigger tumors require big surgeries. All right, so that is the treatment of choice for glomus, that is surgical excision. Now, before I finish this topic, there is a rule of 10 that you must know. The glomus, it follows the rule of 10. What is the rule of 10? 10% are familial. They are hereditary. They run in the families. 10% are multicentric. They have multiple centers of origin. Okay, so that means not one paraganglionic cells, but multiple paraganglionic cells will give rise to the tumor. So 10% are multicentric and 10% are functional. They are secretory. They secrete catecholamines. So that means they can have distant endocrine effects. Okay, so 10% are functional. They secrete catecholamines. All right. Okay, so that was our glomus tumor.